Good morning, everybody. My name's Dr. Avik Dandapat, and I'm here to deliver some really good information for general dentists, all about dental implants. So a little bit about me. I did my BDS from Birmingham back in 2001, and I've done the membership of the Royal College of Surgeons and a diploma in implants at the Royal College of Surgeons. I was on the second cohort ever, and I've done the advanced certificate, and I've got a master's degree in implantology. So I run a course called the Implant Diploma, and we're on stand C35, but what I'm going to do today is I'm going to give you guys all the basic information that you need to know as a general dentist about dental implants. So the first thing that we really need to look at with implant dentistry is the anatomy of a dental implant and kind of what's involved in it, because no doubt if you're an NHS practitioner, you're in general practice, you will see patients who've had implants or perhaps have complications of implants. So we're going to go through the basics of that to deliver you information that you can communicate with your patients in a better manner about the implants that they've already had placed perhaps, or maybe you're even restoring them. So where are we with the dental implant? Well, a dental implant generally is a screw that goes into the maxillary or mandibular bone, and there are several different components of an implant. The screw itself has 300 different manufacturers. They're like cars. So you can have, if you go out there today, you'll see some manufacturers are making implants of a certain brand or a certain type. And I'm going to go through the basic similarities between all the companies when you're actually seeing a patient, because you might not know the company that that particular patient that's seeing you it has had, if they don't know. So often when patients have implants placed abroad, they don't know the implant system that they've had, and you've got to kind of work backwards with them. So here we have an animation of an abutment. This is effectively like when you do a post crown, and it's like the post that goes into the implant. And the connection here that we're seeing is called a Morse taper connection. And this is the most common type of connection of the abutment, or post that holds the crown, into the implant itself. And that's held by a screw, and that screw has a certain torque value to go in. So the really important thing is to understand that you have this screw, which is effectively the root of the tooth, and you have the post, which is the abutment that goes into the actual connection of the implant. And sometimes you'll find patients come with a little bit of a loose crown. And I'm going to talk about that complication and how to actually deal with it and assess it and decide what we're going to do to correct that issue. So you have the screw, the abutment, and the crown, and those three processes go together. I'm going to talk a little bit about that itself. Sometimes you might see a patient, and they might have something unusual on their gum, which looks like a button that's flush with it. So we call this a healing abutment, or a healing cap. So when we place the implant, the osseointegration process, that's where you get the osteoclast actually fusing with the titanium of the implant, is a process that takes 4 months to occur. So in that 4 months, we may place a healing cap, and that creates basically an atraumatic connection between the oral cavity and the insides of the implant. And you can unscrew that without local anesthetic, and you'll have a very clear area of keratinized mucosa going straight to that head of the implant there. So if you see that, and what we're actually taking out with is something called a hex driver, and I'm going to talk about that shortly. So these are the basic things of the anatomy of an implant. Now every general practice should have one of these kits. This is a kit that has what we call hex drivers. They're like little keys that go into the implants. Now even if you don't know the implant manufacturer, if you have this, what we call a universal kit, you can mostly fit 99% of implants that come through your door to tighten them up, okay? The drivers themselves are measured in the actual sizes of the hex at the end of them, okay? As you can see here, we have a 1.2, which is the most common, a 1.25. The Straumann implants use a slightly different configuration, and you have long and short. The reason you have long and short is if you have an upper 7 with a limited mouth opening, you can't get there with your big fingers unless you're a lovely female with small hands. You need a shorter driver, okay? And that'll get you access there. And you can try them out there. So this is a universal kit. And what we're actually seeing is a ratchet as well. You might think, why have we got a torque wrench? Well, that driver fits into the torque wrench, and you're able to actually apply a prerequisite force on the actual driver, which will actually torque that abutment into the implant. And it's really important to understand that different manufacturers of implants will have different torque values, and you have to actually screw the implant down with, or the abutment down with. It's really important to record in your notes the actual value that you're going to actually torque this screw down on, if you can actually tighten it. And you'll be saving yourself a lot of hassle, basically. So, for example, my system that I use in Megagen, they want me to tighten abutments down to 35 Newton meters, and that's 35 on the gauge, on the torque gauge, when you actually turn it. So this is a really, really important area to understand when you're actually dealing with implants in general practice. And they're little components that you need to kind of know about. If you're going into restoring implants, you may find a crown that's supported by an implant and it hasn't got a hole in it. So that would be a cement retained crown. Now in recent years, we've kind of gone away from cement retained and more towards screw retained, because we were finding that we were getting more and more cementitis, or inflammation of the gums due to the cement. And effectively, that margin of the crown is dictated by the abutment. So you don't have to crown prep it like a tooth. And that abutment's made in the laboratory, and if they put the actual margins too far deep into the gum, there's no way you can actually get the cement out. The cement of choice is Temp Bond NE that we use. We usually generally Temp Bond our crowns. But if you can't get the cement out, you'll see it in your x-rays, your parallel IOPA x-rays, and you have to remove the cement, or you will get inflammation associated with the cement. So we tend to shy away from cement retained these days, but there are positions where we have to use them if the implant's actually being positioned suboptimally, which I'll go into. The main thing also is when you have a screw retained prosthesis, you will have a little hole in your crown, and your patient may come, and if it comes with a loose crown, it may be that just the abutment screw has loosened. This is quite a simple fix that every general practice really should know about, is that you drill out the composite, which is usually just flowable composite, and underneath the composite is either a small piece of cotton roll or a piece of PTFE tape. And I usually use a barb brooch to get the tape off, and then I'll get my universal kit out and I'll try what will fit the screw head to see if we can tighten it up. So these are one of the fundamental things that every general dentist should know about dealing with implants, because sometimes your implant patients will come with a crown that's loose, and it could be a very easy fix rather than referring it on where the patient has to wait quite a few weeks. The other issue is, if the crown is loose, it can actually cause peri-implant inflammation, right? And you can get peri-implantitis even, and bone loss, and issues around that, and plaque potential. So a moving implant crown is not ideal. It needs to be either sorted there and then, or sent back to the implant surgeon that placed the implant in the first place. So those are the two types of cement retained prosthesis or screw retained prosthesis that you may see in general practice, and that is a simple universal kit that you can buy. You can even get it from eBay. It's not very expensive. You're looking under £100 for it to keep in your drawer somewhere. The other thing that I really harp on about is understanding about peri-implant soft tissue. Yeah? And peri-implant soft tissue, if the implants, for example, here we can see a full arch prosthesis, it's not ideal because this has been cement retained on a patient with very thin mucosa, very thin gums around there. We've got a muscle pull that we're seeing. We haven't got much thick biotype around the implants. And what implants like is thick biotype. So we do, as the surgeons that do this sort of work, we do a lot of soft tissue grafting. We change biotypes, but if you see this situation, this is partially due to the actual muscle pull that you're seeing, that you can see over here on this picture, that's caused the recession on the implants and exposure. So you might be wondering how to deal with this, because this prosthesis will be actually solid, right? And what you don't want to do is tell the patient, oh well, all your implants have failed, that's it, you're going back to the implant surgeon and he's going to redo it all. You don't want to do that. That's doing a disservice. It's been done. It's probably been there. In this particular case, this patient of mine basically had this abroad about 15 years ago. So it's been 15 years in function. Is it a failure? Well, not really. It's not a failure, but we need to manage the situation going on. And the way you manage it, number one, is you get rid of the plaque that you can see. Okay? So you can use air abrasion technology, and you can clean that up, and you can air abrade the exposed threads. Okay? That's number one. Once you clean it up, what will happen is that the threads are quite rough. Okay? And they are going to be retaining the plaque in the area. So what you want to do is actually get a burr and smooth this out, right, to make it a smooth surface. So imagine root planing on a tooth, right? So what do we do with root planing? We get a scraper and we remove 10 to 15 microns of the root cementum to get rid of the bugs. It's very similar on an implant. When you have plaque retention factors and a solid implant, the bottom of the implant will actually be osseointegrated, but the top of it is going to be something that will retain plaque. That then can cause inflammation. So simply by cleaning the plaque up, giving the patient oral hygiene instruction, smoothing those threads out and do a little bit of local, right, and teaching the patient how to brush and use a TP in between and underneath the bridge, may give that patient a few more years survival with this particular bridge. So it's not all doom and gloom. The fact that, yes, is this suboptimal? It's suboptimal treatment, but it is successful because it's been there for 15 years at the end of the day. So we can't demonize the treatment, and it's really important to communicate with your patients. Don't necessarily go back and say, oh, this is all wrong, this is all done wrong. You've got to work together to understand that there are patients like this, but they can be looked after, okay? The key sign to look at is to press the gums, and if you're seeing active pus coming out of those pockets, that's a red flag, okay? That's active infection that's going on. No antibiotics are going to have basically treat that. It has to be treated surgically. You have to go in and treat that surgically. And appropriate referral should happen. So peri-implant soft tissue is really, really important. Now, the definition of perimucositis is inflammation which may be bleeding on probing, right? Or it may be pus that you see from the pockets. But then when you take an X-ray, you see no loss of bone. The bone levels are really good. So that will be defined as perimucositis. That's an early inflammatory reaction. And that's very, very treatable as a condition, usually by educating the patients in oral hygiene instruction, TP use, and brushing. My first choice of treatment of perimucositis is PerioFlow, air abrasion technology. Okay? So we air abrade the pockets. Now, implants are slightly different to teeth. Okay, as in the pocket depth means very little. So hear me out on this. When we first place an implant and we've done the final restoration, depending on the thickness of the gum that you started off with, that's where your baseline pocket chart should be taken. So we take a 3-point pocket chart around the implant itself, and that might be 8, 10, 11 millimeters. Now, it doesn't mean that implant has any perio disease. It just means that's the starting base point. You then yearly, when you see the patients to review them, you're going to take another pocket measurement and compare it to your baseline. That will give you your first indication if you're getting bone loss on the implant or if there's any issues going around there. Okay? What we do know is really important that patients with pre-existing periodontitis are much more susceptible to perimucositis and peri-implantitis. Okay? So we've really got to ensure when I'm teaching dentists to place implants that patients are periodontally stable. Implants are an elective procedure. If you've got active perio, one of the consent issues that I actually do is actually tell patients that you've had perio before, you've lost your teeth, you're highly susceptible to perio on your implants. And implants need more care than natural teeth to be looked after. Better oral hygiene, more frequent hygienist visits, better interdental cleaning, use of adjunctive mouthwashes. Yeah, we use Curacept implant, a specific type of chlorhexidine around that. So moving on to peri-implantitis. Peri-implantitis is where you have inflammation around the implant, but when you take a PA in practice, you're going to see this cupping effect or bone loss around the implant. And in fact, the soft tissues around the implant may actually look quite normal. It might be pink and it might be just bleeding a little bit, but this is what's going on underneath the hood. The issue is, what's happened is you've got bugs that have come and populated the implant surface, and as a reaction of that, the fibroblasts, those small cells within the actual gum tissue, have started proliferating around the implant itself and creating a granulation tissue. Now, there's two approaches of treatment of peri-implantitis, depending on the degree of bone loss. Originally, the consensus report by Albrechtsen in 1994 about the proceedings of a workshop in periodontology about how to actually treat this. So if you have 50% bone loss with no aesthetic concerns, and your patient wants you to save the implant, it is possible. But you have to raise the flap. You have to physically remove the granulation tissue around the actual implant itself, and you have to actually work out how much of it's osseointegrated. It might be solid. You then have to clean the threads, smooth the threads with a procedure known as an implantoplasty now, which is an accepted procedure, where we smooth the threads out so you don't have any plaque retentive factors, and then you put everything back. Expect recession, expect exposure of the implant, and expect to be communicating with your patient that. So your options with peri-implantitis to tell the patient, yes, we can offer you a solution to save this implant and buy you a few more years. Nothing lasts forever. Or we can count our losses, take the explant it, graft the area, clean it all out, and place an implant 6 months down the line, once everything's healed. Okay? You have to be able to discuss these options with your patients, even prior to referral, that these problems are going on. Okay? What we're knowing now is peri-implantitis, perimucositis is multifactorial and is very much so based on host biology. Okay? And it's the actual medications of your patients. One of the things that we do in our consensual process is say, look, if you develop, you might be fit and healthy today, we placed a whole bunch of implants, in 5 years you've got osteopenia, right? They put you on bisphosphonates, right? And you're getting necrosis of bone, and you're getting bone loss around the implants. Why does that occur? Because your body's rejecting it, because you're immunocompromised. So we need to look at the overall medical history of the patients, give them clear communication of the risks and the benefits of that particular treatment, and be able to manage that communication with them to get better outcomes for your patients at the end of the day. Working closely with your implant surgeon, the main thing is if you have people that are visiting your practice to place implants, what's your long game with them? What happens in 5 years when they leave, right? You're left with all these implants that they've placed. Maybe you have a situation where you have peri-implantitis. Who do you go to? All these questions must be sorted out with whoever's placing them and whose ultimate medico-legal responsibility it is to look after these patients. But we have a duty of care to all our patients, and we need to give them the options. We need to discuss these potential complications of implants even prior to referral and prior to placement. So I'm a great believer in ethical dentistry. I present treatment plans. I don't sell treatment plans to patients. I present them. But these things can happen, and it's about having a robust plan in place on how to treat them. Okay? So that's how we deal with peri-implantitis, but I go into that in quite a lot of detail in my courses. So what do we record, and how often do we record them? So we record implant patients on 6 monthly, so once a year. Okay? That's in my implant practice, because I'm just purely implant, I will see all my implant patients once a year for a recall, and that's outside their normal general practice appointment. What you want to do at the 6 monthly recalls is take an IOPA of it, check all the components are fine, make sure nothing's loose, give the crown a wiggle. That's literally what you need to do now. Give it a wiggle, make sure there's no pain, pus, pocketing, or inflammation. If there's inflammation or bleeding, you can refer to the hygienist at first level. If it's any worse and you see any pus or anything like that, you can either deal with it yourself at first line or refer it on to somebody who knows what they're doing. As I talked about the baseline pocketing, that's where pocketing around implants is more relevant. But we only do that, again, once a year, right? And we're trying to shy away from actually probing implants that are freshly placed, because you could actually introduce bugs within the first 6 months of placement of an implant, which causes bone loss. You compare the yearly bone levels on your implant. Now, Implants were originally done in 1982, right? And we had for a long time, the clinical history actually accepted a bone loss of about 0.2 millimeters a year. That guideline still stands today. If you have less than or 0.2 millimeters of bone loss a year, you're fine. However, with modern new techniques and new innovations coming out, we're actually going to a zero bone loss concept and actually gaining bone around the implants with osteodensification techniques that we're seeing. But, in my opinion, it's very much due to the host factors, their cleaning, their oral hygiene, and their actual susceptibility to perio around the implants themselves. Okay? The other major factor with that is the occlusion, which I'm also going to talk about. So, in summary, the warning signs that we're looking at are any pus, any bleeding that's occurring, any basic mobility of the implants. You need to be able to assess what's mobile. Now, the biggest tip I can give a general practitioner, if somebody comes in and goes, my implant's wobbly, what you do is it painful? Ask the patients, Mr. Jones, is it painful? No, it's just a bit, it's moving a little bit. That normally is indicated the implant's fine and is one of the components that are actually loose. If then they say, oh, it's a little bit painful, and you give it a wiggle and they go, ouch, that's indication that the implant has failed. The bond between the bone and the titanium has failed. So pain, look for that if they're getting pain around there. Generally, if it's a component or loosening of the screw, the crown will just move a little bit. And then, using the kits, you can try yourself to actually tighten it up or not. Now, one thing is really important to understand that when you have a patient that you're referring on for an implant, or if you want to do an implant yourself, they have to have a shortened dental arch. It's widely accepted that you have to have a 5-to-5 rule for the force distribution. Implants love axial forces, that's forces through the middle of them. They hate lateral forces. So any force sideways on an implant will cause bone loss. So what we're seeing more and more today, in today's society, we're seeing more bruxism, more parafunction, people are more stressed. You know, you can look at your patient, they've got big masseters, right? That's mesenteric hypertrophy, because they're clenching. We're working longer hours. So more in my implant practice, I'm seeing more people fracture their teeth, and I'm doing more immediates than I ever did 10 years ago. Because they're fracturing molars, they're fracturing their restorations, and it's the end game here, okay? So knowing that when a patient doesn't have a 5-to-5 occlusion and only wants an upper central done, and we've got 4-to-4 in the lower, we can't do it. Because there's not enough implants to actually, or not enough teeth to distribute forces. Okay? So be aware, if you lost posterior support, you need to have that. Any signs of parafunction. How do we define parafunction? Parafunction is any contact between the teeth that occurs not during chewing or swallowing. So if you all swallow in this room, like that, give me a swallow, right? What happens? Your teeth come together, okay? So the only times your teeth should actually contact is during swallowing or chewing. Outside that is parafunction, because it's function that shouldn't be happening under a normal circumstance. So again, looking out for signs of bruxism, abfraction lesions, broken restorations, looking at mesenteric hypertrophy of the muscles, all of those signs are warning signs. And always look at, when you're referring, why does the patient need an implant in the first place? Implants are not a replacement for root canals and crowns. We've established in the profession that implants are they're for missing teeth or terminal teeth. They don't replace teeth because the patient goes, oh, I don't want a root canal for 3 hours, thank you very much, I'll just have an implant. No, we don't do that. It's unethical, it's indefensible, number one. A natural tooth will outlast an implant all day long. So if you can save a tooth preferred. The other major difference with implants itself and teeth have a buffer. They have a suspension ligament called the periodontal ligament. Okay? This thing can give you feedback. So when you're actually biting down, you will know how much force you're applying. Implants effectively are ankylosed. It's a direct contact. There is no alpha fibers giving any feedback loop to the brain to tell how much force you're putting on implants. Okay? So people tend to bite a lot harder on implants. Okay? Because they don't know how much they're actually biting. So when you've got somebody with a full arch, they have no clue how much force they're applying. So I'm going to do this simple test in this room. I want everyone to put their teeth edge to edge and hold their masters for me. So put your teeth edge to edge and really press down for me. Really press down, hard as you can. Absolutely. What are you feeling? Edge to edge. Nothing. Now, bite on your back teeth, do it again. Now feel those muscles. Do you feel the difference? So that's called the neurofeedback. That is built into us through evolution to protect our incised edges of our teeth. And what's happening is that PDL in your front incisors is sending a signal to your brain saying, do not fire up. Okay? Where's it relevant? In occlusion, a practical thing, if somebody's class 3 and their back teeth are basically biting on the back, they haven't got that protective mechanism. They're breaking their front teeth. If someone's parafunctioning, then they have not got that protective mechanism. You've got to recognize that. We've got to look at the causes of what actually causes tooth loss and tooth fracture and why we're replacing them with implants. So the first thing I do when I assess my patients and I see them, I go, right, why have you lost this tooth? Why have you cracked it? Why is it decay? Why is there perio? What's going on? If you don't treat the cause, if implants not the solution, you've got to treat the cause, which may be parafunction. And it's going to help your everyday dentistry. It's going to help your restorative dentistry. It's going to help your inlays, your onlays, whatever your actual dentistry that you're going to do. If you don't recognize basics of occlusion and basics of what I'm telling you, you're always going to have complications with your work. Okay? Because basically dentistry doesn't last forever, and dentistry is about actually acutely recognizing and diagnosing the problem, and the actual mechanics of the dentistry, be it an implant, be it a root canal and crown, is the solution, but you may not have solved the initial problem. Which more often than not, definitely down south and in Reading where I am, it's occlusal issues and bruxism because people are simply more stressed. We had a big surge of cracked teeth straight after COVID, right, in 2020. Massive, massive number of patients came in with cracked teeth because they were stressed, the businesses were closed, the economy was going to pot. We didn't know what was going on. So we did a lot of implants there, but a lot of people do the implants without knowing, and they're now dealing with their complications of implants. So every general practitioner should know this, be able to communicate that with your patients, and be doing that the way it is. So we generally say natural teeth are associated with high occlusal awareness, and they've got a lack of proprioception of implants. So you can discuss that with your patients. Implants do break. They fracture, okay? And we're seeing it more and more and more nowadays. So your patients, they do get disappointed, and rightly so. They've paid a considerable sum. Implants are between £2,500 to £5,000 a fixture, and they've broken it. The problem is that we're not teaching dentists enough in implant courses. We're teaching them to go abroad and bang in 60 implants. What we're not telling them is how to deal with this situation. So how do we look at this? Fractures of implants, very, very simple to diagnose. Either from the X-ray that you take, and you see something as obvious as this, that's fractured, and that's a clear occlusal issue that may have occurred, or the wrong implant design, with very thin walls, that causes fracture, or the patient's bruxism, or there's an interference on the lateral guidances. Okay? So we need to work out what's caused that. The second thing is, obviously, this implant is unrestorable. And sometimes in X-rays themselves, you don't get to see this obvious fracture. So the easiest thing I can tell you to tell you that it's a fractured implant is when you're tightening that screw, or the screw retained crown, and you tighten it down, and that starts spinning, you just can't seem to get a grip, that's an indication that a component has broken. Which could be the implant, because it's not tightening down, or it could be the screw itself, or the abutment itself that's broken down. So those are the things. You will be sweating, you don't understand, because you don't overpromise your patients. The main thing is if you are tightening things up, just say it could be a numerous number of things. I'll give it a go, right? It may solve the problem, and it may loosen the game, but I might need to refer you on. So you need to communicate that with your patients. Really, really important, because this happens. In this particular case, this is an explantation, so we take the implants out and put another implant in that's wider. We might do some augmentation at the same time. A lot of the work that I do is immediate placement, so we take out teeth, put implants in, use the sockets, and we're getting really good results. The next topic is really about understanding implant positions, okay? And I'll give you a story. I had a referral back from one of my patients that I placed implants back in 2009. Hadn't seen me for years and years and years, comes into my clinic and goes, Avik, my dentist told me you've placed the implants in the wrong position. I'm like, right, yes, so you sort it out. Now, this was many years down the line. So I don't get defensive. I go, okay, no problem. Who's the dentist? Let's get on the phone. And I have a conversation with them. And it's about understanding that you cannot assess the position of an implant from an X-ray. Okay? So do not be quick to pass comment on position of an implant. And trust me, you're going to see some really rubbish work out there. And you're going to see some good work. But it's not in our position as a general dentist who doesn't do implants to say, oh, the implant's placed incorrectly, because it stimulates the patient. It takes a lot of time for us then to explain to the patient what we're doing, demonstrate the position, and actually work with you guys to make sure that everything's looked after at the end of the day. So you can't assess it on an implant position. So here we are with another case of a complication that you might see, and you might have these two implants. And the question being is, the general rule of thumb is that you can creep up to a tooth with an implant up to 1.5 millimeters, right? And you can creep, the space in between two implants should be 3 millimeters, okay? Now, the reason we say that is very simple, it's biological, okay? An implant's ankylosed, it has no blood supply, it's just bone to metal, okay? If you put the implants closer than 3 millimeters, the evidence leads to the fact that there's not enough blood supply coming in to supply that bone, and you get something called necrosis of the bone, and it dies, okay? But what we see here is very evident that the number one, you've got the gum that's receded, the implants are a little bit too close together, right? And this situation can be managed, okay? The reason we can get closer to teeth is because periodontal ligaments have blood supply. They have fresh blood going into their periodontal ligaments, and you can creep up closer because that's not severed. So implants 3 millimeters apart in general, and you can kind of assess that through a CBCT or a very, very parallel X-ray. Or you have this situation. Now with this particular case, again, you talk to the patient, you understand that they have a complication. Now, some people say, right, one of the options here is take out both these implants, graft it, soft tissue graft it, pack the whole thing in. Now that patient who came to me with that complication may not want to spend the £15,000 that's required to fix the situation. So a simple fix would be you take out one of the abutments, not the implants, you put a cover screw on and you do a cantilever from the central to the lateral, and you just let it heal. It's a simple, quick fix that you can tell the patient and do for the patient to restore that situation. And it might actually not even need the soft tissue graft. The gums will just come back down. And if not, you assess it in 6 months and then refer it on to somebody who can do a soft tissue graft. It's looking at simple solutions to a problem, but not making the problem worse. And don't always dive into, let's take these out and start again. Because taking implants out is quite traumatic. You lose a lot of tissue. It's a full invasive surgical procedure, and you may not need to do that. Okay, so optimal implant position. The beautiful thing about where technology has taken us today with implant dentistry is we're able now to remove a front tooth that's fractured, that you can see here, and actually place an implant at the same time. It's known as an immediate placement. And the major benefit of this is not multiple surgeries. We can use the bone with the current implant design. This was a Straumann implant that I placed, a BLT, straight into the socket itself using the palatal wall. And that will save that patient soft tissue grafting, hard tissue grafting, a lot of time, effort, because as we know, when we take a front tooth out, within 6 months they're losing 3 millimeters of bone. They lose the buccal plate. Doing this technique, replacing the implant, it was a fractured front tooth on a young gentleman, and we graft that area around the implant and put a temporary crown on straight away. Keep it off the occlusion. It's amazing technology we're able to do. And for you guys in general practice, when you see a front tooth, early referral on fractured teeth. Because if you don't refer it early, what happens is you get bugs going down the fracture, right to the end of the tooth, and taking out all the surrounding bone tissue and creating an infection. And then we can't place an implant. So that early referral is really, really important. As you can see, on image number C is where an implant's been placed quite late after a tooth has been taken out. And what do you notice? The amount of ridge overlap that's going on, right? The implant is in the suboptimal position because the bone has gone. And someone thrown this implant in, and you've just got this big crown going forward, and it's a disaster. It can cause most of the problems. So early referral for immediate implant is really, really important. The other positional issue, this is not my patient by the way, but if you place, or your implant's been placed too buccally, so you have to think about things in 3D. So we're looking at mesial distal, buccal plating, or buccal lingual, okay, the position. The position is quite important because in the maxilla, everyone in this room looks a bit different, okay? All our maxillas have different angulations of the maxilla. And those front implants have to go in at an angle, and some people have a high maxillary angle, and you end up with quite a slanted implant that you have to then correct to get into the smile zone. If you place it too buccally or outside what we define as the prosthetic envelope, that will end up with exposing these healing abutments and exposing the actual abutments of the teeth. And it's not going to look aesthetic. And your technicians are going to be like, how do I restore this? So again, we need to look at the three-dimensional positioner. We have great intraoral scanners now. We use guides. We use diagnostic wax-ups that can actually give you where the buccal position is, so you know that's where your prosthetic envelope is. So one of the things that I do, and I teach on my courses about acute positioning and freehand positioning first, before we go into guided surgery, which is later down the line. I believe guided surgery is for more experienced practitioners, but when you're first learning out, freehand positioning is really, really important in general. Okay, so that's optimal implant position. Why have we got a picture of a lollipop here? Okay, so a lollipop is because with molar teeth, remember, implants are cylindrical. They're cylinders, okay? You're replacing a molar implant, you're going to end up with a situation like a lollipop. So what you've got to tell your patients, they're going to be annoyed, there's going to be food packing, it's going to be needing to be TP 3 times a day. So what we decided, or what the industry decided, we created Atlantis abutments. But you will generally find the problem of molar implants with bounded natural teeth is that you will get more food packing in between. So again, another conversation that you need to have with your patients about when you're restoring your back tooth implants. And they'll be using large TP brushes for a long time. They need more maintenance than normal teeth. There's new technology coming that we are able now to use angulated screws. This was really exciting. This is the central incisor that I did on the left-hand side, and as you can see, I've got the driver in through the palatal, but the maxillary angle was high, so it's not a direct drive. So the screw they've designed now is on almost like a round ball head, and it goes into the actual screw, and you can tighten it that way at an angle, as opposed to using the hex that's just straight. Major advantage for having screw-retained prostheses at the front of people's mouths, negating the risk of cementitis and the risk of anything like that. So this is an optimal situation where we took the tooth out, placed the implant, restored it with a screw-retained prosthesis back to what the patient wanted, and we're able to save the soft tissue profile. So we had great soft tissue profiles. So in summary, the facts around implants. It's really important to know that implants replace missing or unrestorable teeth. They are not a replacement for root canals and crowns. So if a tooth is savable, a natural tooth will outlast an implant. Implants will only last 10 to 15 years, and implants are optional, elective treatment, and the last treatment performed. You need stable perio, stable dentition, all their dentistry done, their occlusion sorted, and that will be the last treatment performed on your patients. And a shortened dental arch is required. And that's it. Dental implant training in the UK, I'm very passionate about training, as you can see, and teaching dentists about implants, because in England we're very much so behind the curve versus Europe. We only place about 250,000 implants a year. Germany placed 1 million, Italy placed over 2 million implants the last year alone. We're behind the curve because of the NHS, because of the fact that there's not many general dentists accepting implant dentistry as their general practice. Okay? The guidelines now, I have an implant diploma program where you get a formal qualification, you're assessed, and that will be the reference point of any training that you do with the General Dental Council, because they'll consider your training against any complaints that you have in the future. So I'm sorry to say, if you've done an online course and watched a few YouTube videos and you're putting implants in, it may not bode well when things go badly wrong. Okay? This is my institute. I'm based in Reading, in Twyford, a small little leafy village. The building is bespoke to just doing dental implants. We have student courses going on in the diploma program starting at the end of the month, and at the moment we have about 3 places left, so we're sold out. We do a lot of pig's head work, a lot of soft tissue work in the institute, so we do a lot of lectures in the morning, by practicals in the afternoon on every single day. The course runs Friday and Saturday, once a month. It's 12 units for the diploma with an assessment, and you have to do your own cases, and we talk you through everything like that. And we're at stand C35 if you want to come and have a chat with me about the courses and the next course start, and know a little bit more about what I do. But I hope you found this very informative and it was helpful, and thank you very much for your time. Well done.
So in terms of the CPD, how do you get the CPD on this?
It's automatically emailed to you, so you don't have to.
Thank you. I've got one. Thank you.
Perfect. Have a nice day. Enjoy.
Good?
Yeah.